Hello, this is Dr. Jeffrey Spiro, and I'm pleased today to be interviewing Dr. Charles Cummings on behalf of the History Committee of the American Head and Neck Society. One of our missions is to obtain oral histories from distinguished senior members of the field, and Dr. Cummings certainly qualifies in that regard. Dr. Cummings, thank you for joining me for this interview.
Thank you, Jeff, for having me. I'm flattered to be recognized, and I appreciate it. Thank you.
I guess I'll start off by asking you, but just start at the beginning. What got you interested in medicine in general to begin with?
It's a familiar question, Jeff. I have to tell you that there are no medical people, nurses, doctors, or anything in my family. I'm the only one. Before or subsequently, I couldn't convince my 3 kids to go into medicine either. So for whatever reason, it's all that I ever wanted to be.
Okay, so you're going through medical school, and did you go directly into otolaryngology, or were you thinking of other things? What got you interested in our specialty?
I went to UVA, and a fellow named Fitzhugh was the chair when I was in medical school, and of our class of, I think 71 or 2 people, 8 or 9 went into otolaryngology. So he was very much of a Pied Piper for the specialty. I actually went away to do internship and a year of surgery, and it was at that time that I really decided I wanted to go into otolaryngology, head and neck surgery, and I had 2 rotations of 6 months, one on plastic surgery, which I loved, and Claude Coleman was the chair at that time, and he was a head and neck surgeon, and I loved working with him. And then I went on Fitzhugh's service the following 6 weeks, and I recognized that even though Coleman was a wonderful guy, I enjoyed myself more on otolaryngology, head and neck surgery, and they were warring factions. So I joined. I went the otolaryngology way, and Claude Coleman was furious with me for doing that. I remember that very distinctly.
So this is still at UVA?
Yes, it's still at UVA.
So you just stayed there?
Yeah.
So my next question was going to be about mentors. I think maybe I'm hearing one name that you would.
But he was certainly Fitzhugh was certainly the instigator for it, and actually it exemplified the territorial wars that were going on between plastic surgery and otolaryngology at that time, and general surgery as well, as you would appreciate, I think.
Well, we all have affection and recollections of our mentors. Do you have like a favorite story about him that you wanted to share with us, or favorite moment, something he said?
I think that my mentor, my main mentor would be Bill Montgomery. When I got the residency at Mass Eye and Ear Infirmary, I took it. I was in the service and Air Force for 2 years, and then I went to Mass Eye and Ear. But Bill Montgomery, I became a close friend. He was a individual who had a uniquely warm style and was very interested in things other than medicine. And so he was a wood carver, and he was a Vermonter, and I eventually had a house 2 miles away from Monty in Vermont. So we did a lot of playing and talking and socializing together. But he was, I think, the mentor of my residence years.
Do you have a favorite Bill Montgomery moment or story at all, or are there sort of too many of them?
No, it's a good question. There are a lot of them. Monty, and I guess one was I was at that time involved in doing some hard edge painting, and Monty was doing wood carving, and he has one that he made 3 cast bronze studies of. His object was called Natasha, and so we sort of, on his living room wall was painting that I'd done, and on my coffee table right next to my favorite chair was Natasha, and that was sort of the great relationship we had.
Art exchange.
Yeah,
Was
yeah.
he talented as a carver, a sculptor?
Oh, Mario, wonderful. Yeah, he was excellent. That was what made him a unique surgeon, I think, a innovative, creative soul. Yeah.
Yeah, I can see that. I can see that. Well, then the other question that we like to ask in our interviews, given those of us that have been around for a while, was, what was head and neck oncology, surgery or oncology in general, like when you were just getting started? I mean, it was quite different from what it is now.
Long time ago,
Yeah.
and I think head and neck surgery at that time. Well, I went into head and neck surgery really because it's the only malignancy that I know of that people wear it. It's visible. It's in their parts of anatomy that show expression and motion and so forth. And I thought that was the most difficult of all of the malignancies, and probably the hardest trial to bear for the patient's sake. So what happened was there was a lot of extirpation of tumors, and there were a lot of fistulas, intentional and non-intentional. There was a lot of overtreatment in terms of radiation therapy and surgery, and there was essentially no reconstruction, and there was very little attention to function and restoration of speaking and swallowing and eating normally. And it was a time when there was big surgery, and there were no dressings to put over it, if you will.
And I guess there wasn't much else. So this is, this predates, just for the younger folks that we're talking about the era before even pedicle flaps. This is back in the DP flap era, and
Exactly.
The stuff that was quite a while ago. I guess there was any memorable moments from those early days that are a favorite anecdote you have that you wanted to share.
Well, I think there are some actually, and it applies today in that I read the plastic surgery journals religiously during my training and subsequently. And the reason I did that was in it was contained the overwhelming majority of the reconstruction that goes on with head and neck. We were at that time not involved in that. And so I remember distinctly reading about the Bacamsian flap, and then going to the anatomy lab and doing a couple of Bacamsian flap, and then doing the first one at Mass Eye and Ear Infirmary. And the same thing with the myocutaneous pectoral flap. Same process exactly, the first one that was done. And the reason that we could do it is simply that I read other disciplines in addition to mine, and I think that is something that we should continue to do, because there's a vast amount of redundancy, number one, and certainly overlapping competence that is very resourceful.
I don't people remember that the pectoralis flap was described by Steve Arian, plastic surgeon. But you talked about Dr. Montgomery. Was there anybody else, in the early stages of your career who had a lot of influence on you that you could think of?
Mm-hmm. Well, John Conley had a lot of influence on me. I did not take a fellowship with him, but in some way he and I established a relationship, and I was in wonder of his ability to look beyond, again, standard ways to reconstruct, and to tackle previously unsolvable problems and come up with solutions. Very creative person. Here again, he was a man who was an artist, had far more in his intellectual tank than just head and neck oncology.
I was fortunate enough to work with him a little in the twilight of his career, quite the Renaissance man.
Yeah.
He would
Yeah,
poetry and
wonderful.
all those different things there. So, you know, we're talking about, I think you've already maybe partly answered this question, but we would say, you know, the things that you've noticed the most that have changed over the many years you've been doing this in our field. I think you've already alluded to the reconstructive progress.
Yeah. Well, I think that we, as we have matured into not only a reputable surgical discipline, we've become a prominent and leading surgical discipline. And during that evolutionary process, I think we've adhered to the tenets of others, and we've taken the advantage of mechanical miniaturization of different imaging procedures, so that now we're so much better advantaged. We have the imaging. We can hone down. We can tag it with metabolically active dyes. Surgery can be done robotically. So many things that have contributed to a better outcome and a slicker and less surgery that is less violating to the human, I think. Mm-hmm. In addition, same time, we've been able to reconstruct more functionally than ever before, and the whole picture is now coalescing into a much more highly tuned end product that was simply impossible with the technology we had when I started.
Well, yeah, no question. It's been a lot of progress, but then we asked the corollary question, though, that despite all this progress, you know, one of the questions we like to ask is what do you think in the midst of all that amazing technological advancement and such, what's changed the least over all these years that you can see?
Well, I think what's changed the least is the ability of the tumor to have a catastrophic effect on the functioning of the patient. Tumor is still bad. We have different ways of managing it, but the adversary is still very prominent. Despite the observations with respect to HPV viruses and all that, it's still a very significant inhuman and demoralizing and defacing entity.
All right. So when you look back on your distinguished career over these decades, I guess this is always maybe a little difficult question for one to answer about oneself, but we ask all our interviewees, what do you think people will look back and say was your biggest contribution to the field?
I think hopefully one will be that emphasizing that we must always remember the patient and not use the patient as a vehicle to professional advancement, not to overestimate or overtout one's capabilities, to avoid marketing and to avoid misrepresenting your capabilities to the patient. I think of all the things that physicians are vulnerable to, that's probably one of the greatest sins, is to misrepresent what you can do. As a corollary to that, I think one of the great things that's happening is a recognition that head and neck surgeons can only practice the most efficiently if they're in a site where they do a lot, see a lot of head and neck surgery, do a lot of head and neck surgery. And Helmut Gephardt always used to talk about the dabbler.
Yes,
and dabbling does occur, but as we centralize more and more, because of all the technological advances and adjunctive treatments and therapies, I think our results are getting better, and they will continue to get better because of that.
Mm. Now, so I guess this is maybe a bit of a parochial question, looking at it from the perspective of us as surgeons, head and neck surgeons. What do you see as the biggest threat to surgical management of head and neck cancer on the horizon? Are we going to be out of business here in a few years with all these
It's a good
advancements?
question, and everybody worries about that. And my firm belief is that it's a cyclical thing, and we've gone through a number of cycles. We've gone through the radiation cures all cycle. We've gone through a combination chemo-radiation therapy cycle. And yes, sometimes they initially provide astounding results that end up a year or two later requiring a larger surgery than ever was needed primarily. So I think that the surgical world is here to stay, and I think it will be in concert with enhanced miniaturization, mechanization, pacing of nerves, all that, the new wave. But I think that surgery, I cannot imagine that surgery is not going to be required, and even better surgery is not going to be required, because we're creating morbidity that's going to surface down the road.
So I think you've sort of answered the corollary question to that would be then what's the greatest opportunity for us? And I think you've sort of alluded to it already.
Yeah. I think the greatest opportunity is may not involve surgery alone. I think that that certainly may be the workhorse, but all of the ancillary twists that we have and will have, including the molecular manipulation and all that's going to affect the outcome of the patient. I think, the immune therapy that's now surfacing now in lung cancer, non-squamous cell cancers. It's very heartening to see that happening, but it doesn't eliminate the surgical component, I don't think.
All right. Well, then, as I said, you've had a distinguished career spanning decades. I guess a particularly reflective question would be, what sage advice would you offer, those your words of wisdom, if you will, to those young and up and coming in the field when you think about this and look back at it all?
First of all, I would I would compliment them on their choice. I think that there's a hardy elegance in head and neck surgery. I think it takes a unique personality and talent, surgical talent, to grapple pieces of anatomy that are vital for function and for communication and for eating. And it takes some reserve to do that. And I think, so I would compliment the people who go into head and neck surgery. My urge to them would be appreciate how lucky they are to be able to help a patient who is truly seriously in trouble. It's a God-given gift, and I think that I would hope and pray that the young physicians of today and surgeons of today see that, have that, and walk to that tune.
All right. Well, thank you very much for your time. We appreciate it, and I'm looking forward to seeing you engage with us for some time to come.
Thanks, Jeff. I appreciate it very much. Thank you. Great.